Hi, and welcome to the drug sitagliptin. I'm going to focus specifically on sitagliptin therapy. There are over 3.8 million individuals diagnosed with diabetes in the UK. Approximately 90% of these patients are type 2 diabetics. Development of type 2 diabetes is related to insulin resistance caused by desensitization of insulin receptors on tissues such as adipocytes, which cause less glucose uptake and increases circulating blood glucose levels. It is also due to a lack of insulin production whereby pancreatic beta cells in diabetic patients is impaired, leading to a reduced and insufficient level of insulin being produced and released. Sitagliptin is an anti-diabetic medication that acts by inhibiting DPP-4 enzymes to cause an increase in circulating incretin hormones such as GLP-1, resulting in reduced glucagon secretion from the alpha cells and stimulating insulin release by beta cells of the pancreas. Sitagliptin can be given as a monotherapy if metformin is deemed inappropriate, and in combination with other anti-diabetic drugs when monotherapy is seen to be ineffective in achieving adequate glycemic control. Research has shown that sitagliptin is non-inferior to metformin. However, sitagliptin is available only in a standard release tablet form, while metformin is available in tablets, solutions, and in combination with other anti-diabetics. This makes metformin more suitable for people with swallowing difficulties. However, sitagliptin proved that its oral formulation can rapidly release the active ingredient similar to how an oral solution would, while maintaining consistent bioavailability and stability. In terms of adherence, metformin is a one-to-be-taken 3 times a day drug, which therefore can affect compliance, especially in older patients who may be forgetful or already on a vast variety of medications, as opposed to sitagliptin being a one-tablet daily drug which can improve adherence. Studies have shown that sitagliptin also has less gastric side effects in comparison to metformin. Additionally, sitagliptin, when combined with metformin or other anti-diabetic drugs, is expected to further improve glycemic control and also offer potential weight loss opportunity. Sitagliptin is approximately 19 times more expensive to the NHS than metformin. Just over £1 billion was allocated by the NHS for drugs and devices to be used in diabetes. An average cost of £300 was spent on anti-diabetic drug prescriptions for each patient with diabetes in the year 2018 to 19. Overall, precautions should be taken before initiating sitagliptin treatment, as will be explained in the high-risk drug section.
So why is sitagliptin considered a high-risk drug? First, we'll look at how it works. As shown here, DPP-4 enzymes are expressed in tissues such as the liver and gut and have been found to become dysregulated in type 2 diabetic patients. As a result, DPP-4 enzymes bind to GLP-1s at a higher rate, and there is a lesser activation of GLP-1 receptors, negating insulin release while simultaneously inducing glucagon release. Sitagliptin has 3 main groups which bind to the DPP-4 complex. First, we have the beta amino group of sitagliptin, which forms hydrogen bonds with glutamic acid 205, 206, and tyrosine 662 of DPP-4. Second, we have the trifluoropheno group, which sits in the S1 active site between multiple aromatic amino acids such as tyrosine 662. The triazyl piperazine group binds to the S2 pocket with the trifluoromethyl of this group between arginine 358 and serine 209. Next, we'll be looking at the pharmacokinetics. A few key characteristics of this drug is that it is 79% excreted unchanged in the urine, and that elimination is mainly via renal excretion and active tubule excretion. This process is mediated by the HOAT3 and PGP transporters. Moderate and severe renal impairment has a plasma AUC increase of 2 and 4-fold respectively. Special precaution is needed when prescribing sitagliptin, as it is a high-risk drug and can cause severe ADRs. Studies in rat models have shown that increased exposure to DPP-4 inhibitors and increased exposure to GLP-1 causes increased pancreatic ductal turnover, ductal metaplasia, and development of dysplastic lesions. Heart failure is another severe ADR and was found to occur in both those with pre-existing heart failure and those without. The reason for this heart failure is not fully understood, but recent research hypothesizes that DPP-4 inhibitors' action results in stimulation of the sympathetic nervous system, which causes cardiomyocyte cell death. Due to increased risk of both pancreatitis and heart failure, special precaution is needed when prescribing sitagliptin. This leads me to the last point of clinical setting. Patients under 18, those with type 1 diabetes and diabetic ketoacidosis should not use sitagliptin. As mentioned earlier, the AUC increases in moderate and severe renal impairment, and this requires a dose adjustment to 50 milligrams and 25 milligrams once daily, respectively. Monitoring is critical to avoid side effects and toxicity. Renal function, urine electrolytes should be tested before treatment is started, periodically during treatment, and during dose adjustments. HbA1c should also be monitored, and this is mainly done every 6 months to control the condition. In conclusion, sitagliptin is beneficial in controlling patients with type 2 diabetes, but the benefits must be weighed against the risks.